Okay, welcome everybody. It's wonderful to see you all here this morning. I'm just going to give it maybe another second or two to allow you all to trickle in. So good morning. My name is Kara Vincent, and I'm knowledge translator with CIPCERT, the Canadian Institute for Public Safety Research and Treatment. Today, we are so pleased to present the first of a two-part online series, Running on Empty, Managing Fatigue and Burnout Among First Responders and Other Public Safety Personnel. This is a topic that has been much requested by our online audience, so we thank you so much for your interest and for joining us today. So we would like to begin by acknowledging the land on which today's event is being hosted. CIPCERT acknowledges the importance of the land that we each reside upon. We do this to reaffirm our commitment and responsibility in honoring relationships between nations and improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the First Nations, Inuit, and Métis people that call this nation home. Please join us in considering how we can each in our own way move forward in a spirit of reconciliation and collaboration. Tiny bit of housekeeping I'm going to fly through. Please note that in today's session, attendee microphones and cameras have been muted to limit background noise. The session is being recorded and will be made available online shortly via the CIPCERT YouTube channel, and I think you'll find a link in the chat at some point. We have set aside some time for your questions, so at any time throughout today's event, please feel free to enter your questions and comments into the Zoom questions box, and we will get to as many as we possibly can. This event is going to be presented in French with the option of simultaneous captions or auto translation in French. Please use the link and follow the instructions placed in the chat if you want to access this service. Be sure to select French in the top right corner the top left corner, and keep this window open throughout the meeting. I am thrilled to introduce today's panelists, and we're so fortunate to have them here today. Dr. Amin Yazdani is the Executive Director of the Canadian Institute for Safety, Wellness and Performance at Conestoga College. He's an adjunct associate professor at the University of Waterloo and the chair of the Research Ethics Committee and adjunct faculty at the Pacific Coast University for Workplace Health Sciences. Dr. Yazdani holds a PhD in kinesiology from the University of Waterloo and is a certified safety professional. He's also a member of the Executive Scientific Committee on Work Disability Prevention and Integration for the International Congress on Occupational Health. Dr. Yazdani has spearheaded the development of several Canadian standards and guidelines aimed at making workplaces safer and more inclusive, and he chairs multiple Canadian standard technical development committees. His significant contributions have earned him numerous awards and recognition, including the prestigious Young Leader Award from the Standards Council of Canada. Dr. Marcus Young is the Director of Research at the Canadian Institute for Safety, Wellness and Performance. Dr. Young's research focuses on the etiology of work-related musculoskeletal disorders, exposure assessment, fatigue, and development of prevention strategies and interventions to mitigate injury risk. He has expertise in individual level measurement using biomechanical and biophysical tools and uses population level data to better understand exposure disease relationships. Marcus holds a PhD and an MSc in kinesiology from the University of Waterloo, a BSc from Simon Fraser University, and is a board certified professional ergonomist. And finally, Matt Grenier is the Deputy Chief of Quality Improvement and Professional Standards for the County of Renfrew Paramedic Service, a position he has held since 2017. Prior to his Deputy Chief appointment, he was the Commander of Professional Development and has been a paramedic for over 20 years. Mr. Grenier is a leading voice in enhancing the scope and quality of paramedic practice. having been a member of various technical committees for paramedic standards and active in both qualitative and quantitative research. Matt holds a master's degree in leadership from the Royal Roads University in Victoria. So we're so pleased to have this esteemed panel here with us today. Our warmest thanks, and I'm delighted to turn this presentation over to you.
Thank you. Good morning, good afternoon, depends on where you are. Good evening if you are outside of Canada. We're very pleased to join you for today's presentation. For today, I will start with a short introduction and our past projects to support first responders' health and safety by developing practical evidence-informed solutions. For this presentation, joined with Dr. Young, who will discuss some of our recent projects and share some very exciting data about our recent study looking at the impact of risk factors that would lead to fatigue among first responders, including paramedics. Next, please. Next slide, please. Thank you. Just briefly, the Canadian Institute for Safety, Wellness, Performance is the only applied research institute within Canada's college system that conducts applied cutting-edge field research in the area of work and health. We're established in 2019 at Conestoga College in Ontario. And again, our focus and our mission is to generate knowledge, transfer research to practice, and strengthen workforce development by working with partners across the country to help workers stay safe and then be able to improve the productivity challenges that organizations face across different sectors. Next slide, please. Over the past few years, we have done a lot of work with first responders across the country, mainly funded by NSERC, SSHRC, as well as the Defense Research Development Canada. Some of those projects have led to development of several standards and as well as guidelines. Next slide, please. Today's presentation, we're kind of mainly focusing on the paramedics. There's one project in which I guess it will be more applied towards all the first responders, but more or less, we're looking at the topic that I think is very important for first responders across the country. With respect to paramedics, I do not need to perhaps discuss what a paramedic does to this group, but they are our frontline heroes, and they are the key people for public safety. Very generally, paramedics provide out-of-hospital emergency medical care, tending to medical calls, as you know, could kind of again be stimulating and manageable, while others it could be some of the calls might be frustrating, non-urgent, and might be distressing. So the importance of today's presentation on aspect of the impact of what paramedics do during the working hours and the impact it has on the sleep-related fatigue becomes extremely important as we are approaching our evidence-informed risk management when it comes to fatigue among first responders. Other inherent characteristics of the work of a paramedic is that it often involve long hours, shift work, long drives, and being on call, and that could potentially again contribute to the aspects of fatigue that we'll be discussing today. Next slide, please. Over the past few years, we have done a lot of work that informed the development of several guidelines and a standard. And we do have the research that we have done through these projects and the research reports that they produce as a result of our studies in our website, but they're ranging from the projects that we did on work disability management for paramedics to manage PTSI-related injuries, or OSI-related injuries as SIPSearch defines. Also looking at the projects that you've done with fatigue risk management for first responders. We've done a massive research on those, and we're right now currently actually doing a study to follow up on that project as well, which again, Dr. Young will be discussing today. And next slide, please. Over the past few years, research again have informed the development of organizational resources to support paramedic services in reducing workplace injuries and disabilities. For instance, the standard on the ergonomic design of ambulances and graded equipment as an example of one of the, again, one of its kind standards, even internationally, that utilizes prevention through design approach when it comes to design of equipment that paramedics use and utilize. Again, we see standards as a mean of effective knowledge translational tool in which we'll be able to kind of perhaps, if they are developed through evidence, make an impact when it comes to increasing awareness about some of the challenges and some of the issues that organizations will face, and then provide some standardized solutions to help them manage those situations. Next slide, please. Perhaps one of the most important aspects of what we have done over the past few years with the first responders have been the development of first responder fatigue risk management system, which was funded through the DRDC. And really what we did, and that project was one of the projects that we have actually accomplished during COVID-19 pandemic, was to really bring in first responders across the province together to develop solutions that potentially will address fatigue risk management within organizations. Next slide, please. In developing the fatigue risk management standard, can we learn from the past and adopt fatigue risk management system from other industries? That was a question, the first question we've actually faced when we were actually working on that standard. Fatigue risk management historically evolved from safety critical industries and sectors, and fatigue risk management systems are most mature and tested in these sectors. However, we often found that fatigue risk management have not been implemented and tested in other industries and sectors, including public safety and healthcare. We wanted to change that. We wanted to kind of add some value, because we were hearing how different services, they're struggling with aspects of fatigue. The obvious question is, can we just transfer these existing programs into industries and sectors who do not have an evidence-informed fatigue risk management systems? The challenges here is that the work that was done, that is done within public safety and healthcare is not the same. And, you know, we cannot compare them with other sectors, including aviation, for instance. And in many ways, more complex, the work that is being done by first responders in terms of non-routine, they're not on cycles, that there will be some predictability around it, and the nature of the work is completely different. And the other safety critical industries, work is more standardized and more routine. Therefore, there has been calls for, again, constructing a fatigue risk management system, adopting sector specific solutions, tools that could potentially help help us to understand the element of fatigue risk management that is adapted for the specific targeted industrial sectors. Next slide, please. Now, there are few studies or current initiatives that have developed or investigated the effectiveness of fatigue risk management programs. And again, these programs perhaps are not as structured as what we have put together for this standard. And we're looking at some of these that they were not done in Canada. Can they be applied in Canadian context? So, you know, the answer that we had for this was that, you know, some of these elements are consistent and appropriate, but it's missing that Canadian context. And the focus on the multidimensionality of fatigue where these existing guidelines focus on is sleep-related fatigue. So when you're looking at fatigue, what we've tried to do was not to only look into factors in isolation, not looking to just sleep-related fatigue, but the combination of factors, as fatigue is in fact a multidimensional phenomenon. So in Canada, there has been research that studied the effectiveness of programs to manage fatigue-related risk. However, these studies, although very important, often do not speak towards the process of fatigue risk management, but are rather individual programs. So these existing initiatives underscore the need that we have that will really be looking at direct solutions that would help improve workplace practices and policies through the development of standardized framework for first responder organizations. So what we did, we tried to kind of create those standardized practices and policies that, again, one caution here is that standards are consensus-based, and every research evidence that we brought forward had to go through a very structured consensus-based process, in which in some cases perhaps you could see that some of those evidences were not fully adopted. Next slide. What are the elements of fatigue risk management system? Again, if you advance this slide a little bit more, you will see that the title as well. Fatigue risk management defined by Lemon consists of the following elements. So management policy, risk management, reporting processes, incident investigation, training and education, internal and external auditing. The elements are new and in fact are consistent with existing management system framework that we described in our previous research, adopting the RACE model, a continuous process to recognize or identify hazard, assess risk, eliminate hazard, and control risk, and evaluating controls and manage changes. So what we did, we tried to kind of adopt that framework, try to kind of learn from the other disciplines and that we've kind of adopted these processes from, and be able to kind of have some structure around. Next slide, please. And again, there are challenges that we face, and we're hoping to kind of be able to address those challenges through the standard. The first challenge is addressing the what. Is that fatigue has no definitive definition. If I were to ask how people define fatigue and what it means to them, we would get highly variable responses. What we do now is that fatigue is multidimensional, and because of the multidimensionality of fatigue, we ask ourselves, what is fatigue and which type of or domain should we address? The second challenge refers to how, and that how is fatigue is measured, and how we evaluate fatigue. How is fatigue related risk assessed, how we actually do the risk assessment when it comes to fatigue, and how should we effectively control for fatigue related risks and hazards. Due to the complexity of fatigue, which many potential risk factors and physiological mechanisms that may exist, there is no definitive process or instrument or tool to measure and assess all these dimensions. So you have to apply and utilize a number of tools and measures to be able to kind of fully understand fatigue. And fatigue is also task dependent, and different measures and measurement tools are sensitive to the task performed by first responders. So we ask ourselves, how do we inform organization on how to measure and how to manage fatigue and the fatigue risks? For this presentation, again, we'll focus on measurement as when we know the extent of fatigue and the associated risk and possible outcome, we can then properly develop targeted controls and interventions. Effective measurements will also allow us to assess the efficacy and effectiveness of controls and interventions and adjust the solutions to better reduce fatigue and fatigue-related risk. Again, I'm not going to go through the whole process of what has been done and what we kind of got in here. But as contrast for this fatigue risk management standard, we're looking to physical fatigue. We kind of looking to mental or cognitive, emotional burnout, and perceptual fatigue. And we look into the acute, cumulative, and chronic fatigue. Different type of fatigue and outcomes, including sleep-related factors, task-related factors, and personal factors. And again, Dr. Young's presentation later today really focused on some of those aspects as well. And also kind of understanding the predictors and how those predictors will have a role to play when it comes to measuring fatigue and implementing an organization-wide fatigue risk management system. Next slide, please. So, sorry, next. I forgot to perhaps ask you to advance this slide. Apologies. So, to help understand the scope of this standard based on the type and domain of fatigue, we kind of look into the scientific evidence in first response to understand the type of fatigue related to risk factors and outcomes. And this example, within the paramedic literature, there is a clear risk between several risk factors related to task and work, linked to burnout, mental and sleep-related fatigue, and physical fatigue, which are associated with various well-being, mental health, physical health, and performance effects. And again, that paper is a published article. Dr. Young led that paper, and I think kind of gives you that understanding of what factors will have a role to play when it comes to different domains of fatigue. Next slide, please. And if you look at this is true across firefighters, police, and as well as, again, paramedic literature. Here we demonstrate that across each first responder group, fatigue leads to performance, physical health, and mental health and well-being outcomes. And this, again, we're looking at adverse outcome. This ultimately demonstrates that there is a need for an integrative approach, recognizing fatigue in its many forms, as they are related to several type of outcomes identified that will be important and will be impacting first responders' health and safety and well-being. And again, that then consequently will impact public safety. Next, please. So for the purpose of the definition of, and again, we talked about there is no definitive definition. What we tried to do with that standard and with that framework was that we look into a comprehensive definition of the standard. And so we came up, after many hours of consultation, we came up with this definition as that the fatigue is a multi-causal, multidimensional phenomenon experienced by all people. And type of fatigues can be considered acute, accumulative, or sleep or task related. So we kind of try to kind of take an integrative approach in recognizing fatigue in many forms. The other challenge that, again, we had and we faced was around the complexity, and that there are many potential risk factors and physiological mechanisms that would impact fatigue, and the fact that fatigue is task dependent. So we kind of, again, looked into some of the factors. If you advance this slide, in the next slide, I think what we've tried to do is to identify some of these risk factors, and based on the literature, and then be able to kind of see how the standards can provide some frameworks in which the organizations will be able to identify these factors and be able to effectively manage these factors. So through these standards and the appendices within these standards, we identified assessment tools that will help identify and potentially help organizations assess those risk factors. Next slide, please. So our strategy that we did when we adopted was to kind of arranging and categorizing the measurements and the tools based on the practical elements, And again, what we did was we adopted a Sabine method. Is screening, observation, analysis, and expertise. Depends on the difficulty of adopting those tools and be able to kind of provide a level of kind of knowledge in which the paramedics organizations, firefighter organization, the police services, they will be able to kind of, based on the complexity and the knowledge required for each of these tools, will be able to adopt the tool that is more appropriate for the maturity level of the organization when it comes to fatigue risk management. So there's some sort of scalability of what you can do and what you can use to better assess the fatigue. And again, the whole idea was to, if we have early adopters, if you have an organization that just want to start looking into fatigue, what is the simplest way that they can look into it? And if you are a organization that you're mature enough, you've done a lot of things and you've adopted a lot of risk assessment techniques, what are those gold standards or those type of tools that they perhaps require more expertise to be adopted for addressing fatigue? So the standards really kind of outlines a lot of these requirements and provide a lot of suggestions when it comes to selecting appropriate way that you can actually evaluate fatigue. Next slide, please. So what we did, according to Sabine method, as we move from a screen to expertise method, the precision and resolution of tools increase. Because again, the ones that they're more precise, they are the ones that they require more expertise. But at the consequence of higher resources. So you need more personnel, you need more, perhaps you need a consultant to help you, and so on. So as we move from screening to expertise method, the tools are capable of measuring the effect on individual rather than groups. So the scope and coverage decreases and the measures and the tools become more specific to detailed risk factors. So again, there are some pros and cons of what approach you can take, but again, the standard in the annex, one of the annexes, we have these outlined as well. Next slide, please. In the standard, we systematically assign each available measures and tools for all type of fatigue based on Sabine methods. So you have them for different types of fatigue. Again, that would help to facilitate organizations in being able to select appropriate tools and techniques to address fatigue. Next slide, please. So to kind of summarize this section about fatigue risk management standard and the capabilities of this standard has, I just want to kind of summarize a few points that I discussed before I hand it over to Dr. Young. One is that fatigue is linked to performance and health outcomes, both in the short term and long term. And we have to take an integrative approach because performance and health decrements are not linked to a single type of fatigue. So it's very important that you have that appreciation and be able to adopt that approach. Also, another point is about constructing a sector-specific fatigue risk management system while looking at fatigue in its many forms and in many risk factors. Another point that's very important is that do your due diligence in selecting what measures you want to use. Again, if you're just kind of early adopters, do not look into perhaps something that might be very sophisticated to use. Again, might be very sensitive, very important, very accurate. But again, you can build this up. You can actually have some scalability of what you're going to be using to measure fatigue. And also another aspect of it is that I want to kind of, as a takeaway, is that you got to be looking at all factors when you're selecting a measure. So do not only look at precision, look at the cost, the coverage, and the breadth of variables and risk factors that you're looking at. Then that approach becomes more sustainable and again, more cost effective. Next slide, please. I now hand it over to Dr. Young, our Director of Research, to discuss a recent study on this topic to better understand the impacts of fatigue, risk factors on paramedic fatigue. Dr. Young?
Great. Thank you, Amin. Maybe just to begin, when we were co-developing this fatigue risk management standard alongside our service partners, we did identify several scientific gaps in the fatigue first responder space. Next slide, please. Just to revisit that slide that Amin described earlier, as we indicated, there's many risk factors associated with all types and forms of fatigue. So when we were generating the evidence for the standard, there unfortunately lacked empirical evidence on which risk factors were strongly associated with fatigue outcomes and how they may possibly interact. So together with our partners, through an NSERC-funded research grant, we investigated the impact of fatigue risk factors on paramedic fatigue by taking that iterative and systems-based approach outlined in the fatigue risk management standard. Next slide, please. So for this study, we collaborated with a large urban and rural Ontario paramedic service to identify the extent of fatigue by type and dimension, and this was done through a service-wide survey, and to identify possible fatigue risk factors and also quantify work demands. And this was done through a cohort study using actigraph watches. Again, the objective here is to investigate those relationships between the factors and the possible fatigue-related outcomes. And this allows us to develop targeted interventions and strategies. Next slide, please. So from our service-wide survey of paramedic personnel of 280 participants, on average, they were 34.4 years of age. Almost 60% were male, and the majority were primary care paramedics, and the mean service tenure was 9.3 years. Almost 2/3 of our sample were scheduled in a rotating shift. Next slide, please. We surveyed participants using 2 validated instruments. We first used a screening observational tool, again, according to that Sobane criteria. And the tool we used was the Swedish Occupational Fatigue Inventory. And this was used to identify current fatigue levels based on cognitive, physical, and sleep-related fatigue dimensions. We found statistically significant differences between types of fatigue, where physical fatigue was significantly lower than all other dimensions. Sleep-related fatigue, however, was significantly higher than all other dimensions. So given the higher prevalence of sleep-related fatigue in our sample, we used the Epworth Sleepiness Scale, which is what we deemed as an analyst level tool, to assess the potential level of risk due to sleep-related fatigue. According to our results, almost 1/4 of respondents were classified as having moderate to severe excessive daytime sleepiness. Next slide, please. So now, having identified sleep-related fatigue as the most prevalent fatigue type in this cohort, we conducted a cohort study to monitor and measure responses associated with sleep-related fatigue. We considered 3 categories of risk factors grouped as either workload factors, which involves physical, mental, and emotional demands, work arrangement factors, including shift type, work hours, and geographical service location, and personal factors such as age, sex, BMI, experience level, and chronotype. Next slide, please. So here's a visual representation of our general data collection methodology. At the time of enrollment of the field cohort study, we recruited 63 participants across the urban and rural paramedic service. For each service, we captured actigraphy data from these participants over a 28-day period, and we repeated this over 2 additional follow-up periods, 4 months apart. This resulted in over 84 days of actigraphy information from each participant. During each follow-up period, we collected workload, work arrangement, and personal individual data that we linked to each work shift over that 84-day period. Next slide, please. We measured sleep-related fatigue using actigraph watches, which uses validated algorithms to calculate sleep-wake cycles, sleep duration, sleep quality, and other sleep parameters. So as a tool, it's often viewed as an effective low-cost solution for field and workplace studies, having high accuracy compared to gold standards, and serves as a reliable objective measure compared to self-reported sleep diaries or logs. Next slide, please. So this is a busy slide, but here basically we're trying to graphically show the three categories of fatigue risk factors: workload, work arrangement, and personal factors, and the individual fatigue risk factors embedded within those categories. The fatigue risk factor data was obtained from three sources: through ambulance call reports and administrative data from the service, and survey data from participants via sleep diary logs. Data sources were linked together via research participant ID codes and subsequently linked to actigraph data on a day-to-day basis. Again, this was done for 28 days across each of the three collection periods, resulting in 84 days. Next slide, please. So from the actigraphy data, we calculated 9 outcome metrics of sleep-related fatigue, which are listed here, and that includes total minutes in bed, latency, total sleep time, sleep efficiency, number of awakenings, average awakening length, movement index, fragmentation index, and sleep fragmentation index. Participants also filled out a daily sleep diary log to verify and support our interpretation of their actigraph data. We also use the sleep diary logs to identify their chronotype and also gather that demographic information. The administrative data provided work arrangement information and also allowed us to link actigraph data to a paramedic's day-to-day work shift. And this includes absences and training days. And from the ACR data, we were able to quantify the workload for each shift. Next slide, please. So just revisiting my busy slide here of fatigue risk factors. As mentioned, many of these factors are available to us, with the exception of, next slide, workload demands. These are the workload demands associated with procedures performed by a paramedic for each call. So to address this, for each call, we created a intervention demand matrix. And this was based on physical, mental, and emotional or frustration-related aspects for the procedures performed by paramedics that can be retrospectively assigned to a paramedic's ACR data. So next slide, please. Our intervention demand matrix, or IDM, was based off of the NASA TLX, which is a validated survey instrument where we can ask participants or paramedics and frontline personnel and management to provide their expert self-reported estimates of the physical, mental, and emotional demands related to their procedures. Demand estimates were obtained for 64 commonly used 3-digit procedures based on ACR codes. Previously, similar expert or worker-rated demand exposure matrices have been shown to provide reliable estimates for job and task exposures and demands, and have demonstrated comparable results in calculating exposure disease associations when compared to direct measurement. So for each procedure or intervention, we calculated a Windsorized mean that can be assigned to that procedure. Next slide, please. So this is the intervention demand matrix that we've calculated based off of our preliminary data. Each row here is a procedure or intervention, and each column is the mental, physical, or emotional related demands. And the fourth column here is the overall demand score, which was calculated by taking the average of the 3 demand types. The colors represent the demand score split into high, medium, and low levels, respective to each demand. Interventions are organized from the highest to the least demanding according to the overall demand score. So again, these demands were then retrospectively assigned to procedures and interventions so that we can calculate a frequency weighted average for each work shift as well as a cumulative score by summing the demands across the interventions performed across all calls in a given work shift. Next slide, please. So this is our Spearman correlation matrix that portrays positive or negative monotonic relationships between 1 unit increase in work variables and 1 unit change with sleep variables. So we found, so the color gradients here represent the level of statistical significance, where dark green and bolded are correlated pairs that demonstrated strong statistical significance. And generally, we found statistical significant weak to moderate correlations between these pairs. Just notably, without going into too much detail here, of those that demonstrated strong statistical significance, we found that increased call volume was correlated with increased sleep efficiency, as well as total call time with the number of awakenings. We found that increased average physical demand for the day was weakly to moderately correlated with decreased sleep efficiency, as well as increased cumulative mental, physical, and frustration demands over a shift were weakly to moderately correlated with a number of sleep parameters or sleep outcomes. Higher BMI was moderately correlated with reduced total minutes in bed and reduced total sleep time, but increased age was significantly correlated with increased sleep efficiency and reduced number of awakenings and reduced movement index and sleep fragmentation index. So the more advanced age, the increased age, we found that the sleep outcomes, quote unquote, improved. And this was similar to the job tenure relationships that we found. Based on the variable female through a point-based serial correlation, we found it to be weakly to moderately correlated with increased sleep latency and decreased sleep efficiency. So unfortunately, the female variable, there is a little more concern when it comes to some of the sleep-related effects that we observed based on the watches. Next slide, please. So finally, we wanted to further understand the relationships between fatigue risk factors and sleep-related fatigue by predicting the probability of being considered a fatigue case. We defined here a fatigue case as a sleep event with less than 85% sleep efficiency, with more than 6 average awakenings per night, and for each awakening, for the length to be greater than 5 minutes on average. The case definition here is quite conservative, as it reflects both adverse sleep quality and sleep duration. It's important to note, though, that even in the short term, having poor sleep increases the risk of committing an error, an accident, or sustaining an injury in the following work shift. Covariates in our analysis were personal factors, and we performed logistic regression. So today, we'll present preliminary results of our univariate analyses, presenting both crude and adjusted models. Next slide, please. So here's our table of results. Crude models are reported on the left and adjusted models on the right for each risk factor. And again, we grouped them according to workload-related factors and work arrangement factors. Of the workload factors, before we adjusted for the paramedic personal factors, we found that moderate number of calls, which we defined as 2 to 3 calls per shift, was protective, which was about 65% lower odds than odds for having no calls. Trends also show that as the number of calls increased thereafter with 4 or more calls per shift, we found that the trend indicated that the odds of being a fatigue case increased. For both crude and adjusted models, we found that there was a 1 unit increase in the number of interventions per shift related to an increased risk of being a fatigue case by 4%. Transfer of care wait time and total call time increased the odds by 1% for every minute increase according to our models adjusted for personal factors. We also found a relationship between 1 unit increase in the average mental, physical, emotional demands of the intervention per shift and the risk of being a fatigue case. And this was between 3 to 5%, according to both accrued and adjusted models. With every 1 unit increase in cumulative frustration demands over an entire shift, we found a 1% odds increase in being a fatigue case. So not only do the number of interventions per shift increases the risk, but also the call complexity as well. Although we didn't observe a statistically significant, although we did not observe a statistically significant relationship between shift type and the risk of being a fatigue case, one might interpret this that shift schedule alone may not increase or decrease the risk of suffering from adverse sleep-related fatigue, but we also have to consider workload, and that includes the call complexity, the call volume, the drive and call time, the wait time, as well as the number of interventions. And as these were strongly associated or were associated with sleep-related fatigue. Next slide, please. So just to summarize, I know I have 1 minute left, so I think we're on a good pacing here. From our research study, we found that workload factors demonstrate significant associations with adverse sleep-related fatigue, and it's not just work shift types or schedules. We identified a unique U-shaped relationship on the basis of call volume, where there could be an optimal number of calls that was a little more protective compared to the no-call situation. This U-shaped relationship is actually pretty consistent with similar relationships seen between workload and fatigue of different types, including cognitive and physical, including some of the papers that we've written when it comes to physical fatigue and recovery. We found that with increasing number of calls, the call complexity, including the number and demand of procedures and interventions, increases the risk of being a fatigue case, again, using that really conservative case definition. So where does that leave us? I think there's opportunities, as always, for future research. There's definitely some limitations, but there is opportunities for future research in terms of tuning that intervention demand matrix. So we are continuously working with our partners to not only provide more self-reported information so that we can increase and improve the precision and accuracy of our intervention demand matrix. We're also exploring the opportunities to collect more direct measurement so that we can then assign appropriately not only the interventions and procedures, but we could also assign more accurately what paramedics actually do in their day so that we can have a better estimate of not just the demands of their calls, but the demands of their entire work shift. I think there's an opportunity to investigate the effects of sex, gender, and age, and this was based off of some of our correlation matrices results, as well as the odds ratios that we've observed when comparing crude and adjusted models. I think this supports ultimately demographic-specific resources if we do see an effect of sex and gender. Of course, we like to create more robust models with additional data. We're also exploring multivariate modeling, and the anticipated result, more tangible result at the end of the day, is for us to develop a dashboard-based tool to allow services to visualize risk-based prediction models based off of the research findings. So having said that, I would like, on behalf of our team, as well as Deputy Chief Grenier, we would like to thank CIPCERT for the opportunity to speak to your audience. And we would like to thank the paramedic participants and the services who graciously gave us their time to pursue both the standard development process, but also this larger research study. So I think we're more than happy to field any questions from the audience. Thank you very much.
Thank you so much for that wonderful presentation. And I would remind our audience that you can please place any questions you might have in the chat, and we have some time. We'll try to get through, sorry, not the chat, the question box, and we'll try to get through as many as possible. And to our presenters, I see that we do have some in the chat as we speak, if you'd like to take a crack.
Sure. Maybe I'll start. I think the first question is related to one of our slides looking at the relationships based off of the scoping review between fatigue risk factors, the intermediaries, and the outcomes. And I think the audience member noted that there was a negative sign between burnout and alcoholism. I think just to clarify that figure, it was on the basis of statistical significance rather than the direction of that relationship. So in that case, it was not necessarily indicating that burnout was negatively correlated with alcoholism on that slide, but it was just that that relationship was not statistically significant. And the second question part of that was, were correctional officers included in that research and work? Well, in our scoping review, we do have to restrict our the scope of our systematic review. The reason behind that is that even it would further expand the size, the number of papers to review. We decided more strategically to exclude correctional officers in that research study, in that scoping review. However, I think that is an interesting idea to pursue in the future to see the potential effects and whether that research can be extended with correctional officers. I can keep going. Amin, Matthew, do you have anything to add on this?
You're doing good, Marcus. Go ahead.
We're good. Is BMI used as a measure of fitness? Well, that's a really interesting concept. I think as kinesiologists, one might argue that BMI may not necessarily be a good, accurate measure of fitness because one could be dense and strong and have a lot of musculature, but also have a high BMI. But I think it's actually a really good proxy, though, of a measure of health and health status. And that's why we used BMI as a covariate, as a personal covariate in our modeling. And BMI has been shown in some of the literature to be related to sleep-related fatigue issues. Okay. Yeah, I feel like I'm taking up most of this too. I mean, Matthew,
Sure.
would you
Yeah,
like to
I'll
add
give you
anything?
a break. They are, the question is about our RCMP, and that the study. The study that we did was mainly focused on the paramedics. The fatigue risk management is about how do we define first responders were paramedic, police, and firefighters. With the sleep study, we're having some discussions with some of our partners on the police side that there is so much interest in launching the same study that we have been doing with paramedics on the police side. I mean, that's a sleep study. So if there is an interest, please connect and we can have a discussion as well. Did you or anyone that you know of particularly?
Yeah, I can answer that one. So the fifth question here is, did you or anyone that you know of put together a chart of tasks or call types and stressors associated with them for other types of services? So I think this is referring to our intervention demand matrix. So again, it's a really unique concept for paramedic research because again, that information was not available to us. So unfortunately, because it's such a novel way of looking into assessing and identifying and estimating demands, that information is not available to police services or fire services as of today. However, the area of research that we have been conducting and creating job and task exposure matrices, including potentially intervention demand matrices, I think there would be an amazing opportunity if we can to explore those services so that we can develop job-specific IDMs for them. Again, there's utility in similar IDMs and broader epidemiology studies so that we can understand clearly the relationships between workload and risk factors, not just fatigue risk factors, but any sort of risk factors that might be derived from work or outcomes, risk outcomes derived from work. I'm sorry.
I can probably take question number 6. The study was used primarily at multiple levels, like day shift and scheduling, like continental scheduling, so night and day, and both at the leadership level and practitioner level. But we didn't use any standby or on-call paramedic. And the duration of shift is mostly a 12-hour or extended hour shift overrun.
Thank you, Matthew. Question 7, have we considered the age of the candidate to see if that impacts the results? So yes, age was a covariate, was a personal factor that we included in our models, just based off of the Spearman correlation. So again, looking at the associations between individual risk factors and individual sleep metrics, we did find that with increasing age, the correlation was inverse, meaning that with increasing age, we saw that the sleep outcomes, and I hate to say this, improved, but I'll use that in quotation marks. And again, remember what age is. Age is intertwined with everything from job tenure, and job tenure might also include seniority differences, and maybe you could see differences due to not just age alone, but due to other variables that are intertwined with age, including job tenure. I might have missed it, but how are you defining and measuring emotional and psychological demands and differentiating them? That's a great question. We used the NASA TLX, which is a validated instrument that have been used in aviation to determine and assess the 3 types of demands. Again, physical, mental, and frustration related. We just used the term emotional when it came to describing the frustration related demands that would be captured through the NASA TLX. And have you seen any differences between new grads that are paramedics versus 5 or 10-year veterans? I think that's an amazing question to ask. I think with more additional data, which includes paramedics that represent those groups, we can learn and tease out those relationships.
Can probably take the and there at least started. The question is a great question, and I think it's something that we need to continue to work with Dr. Azimi and Young. What we see from a service perspective and what Marcus talked about is the dashboard, and how do we actually identify the risk factor and be able to correlate that with our staff that are on the road. So just practically, let's say you have some people who have some risk factor and some fatigue risk, and we can identify and we can actually, put a threshold where the risk is too grave for them to complete their shift, or they are a fatigue risk that can create error and accident and so on and so on. We need to operationally think differently how we support these staff. And from a HR perspective, is like, how do you retain your staff, ensure they're not going on leave or on burnout, and how do you actually put stuff in place to ensure that you're looking at your staff wellness before the symptom actually trickle for them to go on leave. So a lot of work that we can do on that, but this is the initiation of us to having a picture of fatigue and actually qualifier that we can actually look at.
And just to, as an extension to that, Matthew, that's a really good point. What we view fatigue as is that it's as an important intermediary, but so I think we can see it as an outcome in itself. But with increased fatigue, there is strong relationships with increased risk of committing an error, being involved in an accident. And this all affects downstream things like your patient quality care, the level of patient quality care. And to the paramedic themselves, fatigue is also related to injury outcomes. So it's recognized as a possible precursor to, let's say, musculoskeletal disorders when it comes to low back pain, shoulder pain, things like that. So I think that's where we kind of view where fatigue sits and how important it is. And if you can reduce and kind of manage fatigue, then there's a possibility, and high possibility, to also manage the other downstream effects as well.
Thank you so much. I hate to be the one to have to stop this amazing conversation, but I'm going to have to wrap things up here today. I want to extend my deepest gratitude to our panelists, Amin Yazdani, Marcus Young, and Matt Grenier for their insights today. And I would like to thank our audience as well for engaging with your insights. And I realize that there are a ton of questions that we weren't able to get to today. So I would strongly encourage you to please join us for part 2 of this discussion, where we'll have a panel of experts on sleep, fatigue, burnout, and stress among public safety personnel. And completely devoted to audience questions. So we would invite you to join us for that. And I think there should be a link in the chat for if you want more information or to register. Please join us. And again, I just want to thank you all so much. And we'll be sure to collate the questions we weren't able to get to today. And hopefully we can incorporate those into session 2. So thank you so much again, and I hope to see you soon, and have a great day, everybody.
Thank you, everyone.
Thank you. Bye-bye.
Bye-bye.